Hi, welcome to my presentation, Searching for the Sasquatch, throwing time, money, and effort at mechanistic predictors for responders to manipulation is a mythical journey. I'm pleased to be able to present at this year's San Diego Pain Summit with this topic that was initiated through a conversation that I had with Corey Blinkenstaff back in 2019. We discussed how we need to shift our understanding of how and why treatments have their effects and how research dollars could be better spent. And through his encouragement to present this, I've gone through the process and here I am. So what I'm going to look at in this presentation is how we've tried to find that mechanical predictor and how that hasn't worked well. Also going to explore why I think we keep searching for it, what needs to change, what better predictors for who would respond to care is, and why I'm encouraged by the current state of the research. As part of most presentations that happen here, at least in British Columbia and in other locations, we do a Indigenous land acknowledgement, and so I'm going to do that now. So we acknowledge and thank the Lekwungen people, also known as the Songhees and Esquimalt First Nations communities, for allowing us to live, work, and play on their lands. We also give thanks to the ancestors, supernatural ones, hereditary leaders, and matriarchs, creatures big and small, for looking after the rich resources and cultural teachings of this beautiful land. I find that that's fairly appropriate for the title of my presentation with the Sasquatch and talking about supernatural creatures, where that idea emerged. My name's Dr. Richard McIlmoyle. I am on the board of directors for the Canadian Chiropractic Research Foundation. I'm an instructor with PainBC. I am an owner with my business partner at Achieve Health, Chiropractic and Massage Therapy. I provide some educational content for both the British Columbia Chiropractic Association and the Canadian Chiropractic Association, as well as provide education through my website, drrichardmcilmoyle.com. I feel it's important to identify our bias in how we see things and how we, see the world, and these are a few of the biases or the things that have influence on me because I'm paid to do a few of those things. Additionally, for those of you who don't recognize the image here, it's the Sasquatch battling Steve Austin, the $6 million man, otherwise known as the Bionic Man. So this is aging myself, but this is one of my earliest recollections of the whole Sasquatch myth, and it stuck with me. So what we're going to look at first is the clinical prediction rules that have emerged and also some ideas on subgrouping that have been created or explored in trying to understand who is going to respond to spinal manipulative therapy. We're going to use that as the example, but this exploration of trying to find responders to care has happened for multiple different interventions. So what we will see here is we'll look at a few different papers and kind of look through the arc of the history of clinical prediction rules and subgrouping for low back pain and spinal manipulative therapy. There are 4 papers that we're going to use to follow the arc of the history of clinical prediction rules and subgrouping for low back pain and spinal manipulation and those who will respond. Going back to the origin of a clinical prediction rule that was created will be our first stop on the tour. The clinical prediction rules, or a clinical prediction rule that was created by John Childs and Julie Fritz, who are two prominent names in the clinical prediction rule and low back pain realm. This emerged out of several years of research, but they came up with a 5-item clinical prediction rule that if you had 4 of the 5 items on the clinical prediction rule, you were identified as someone who would be a likely positive responder to spinal manipulation. They came up with this they established it in 2004, and there's been a few studies to challenge it or to examine it and validate it over the subsequent years that we'll discuss shortly. The predictors that they look at, the 5 different predictors that they have, are the duration of the current episode, the extent of distal symptoms, like not having symptoms below the knee, the subscale on the fear avoidance belief questionnaire, specifically the work subscale, then seeing if you have reduced mobility at segments in your lower spine, in your lumbar spine, and then a reduction in hip internal rotation in one of your hips. So those 5 things, if you have 4 of those 5, you are likely to respond well to manipulation. That's the clinical prediction rule that they came up with. Now, it's been examined through some randomized controlled trials, as well as some previously performed trials with manipulation, where they were able to retrospectively go back and look at the data to see if their clinical prediction rule was valid to predict those who would respond. And the 2 of the randomized controlled trials that were done to validate it failed to validate the clinical prediction rule. One of them, performed by Chris Mayer, identified that there was no difference in being able to predict any better than chance in a predetermined group of patients with low back pain who were given manipulation versus sham manipulation, I believe that one was. So this clinical prediction rule has stuck around, and it's referenced quite frequently throughout the literature since it was published. Unfortunately, it doesn't hold up when it's challenged. It has shown some positive results in some studies, but it has fallen apart a few times in a few different studies. So the next one we're going to look at is the researchers out of the University of Alberta, or at least one of the researchers there is out of the University of Alberta, Greg Kotchuk, working with lead author Arnold Wong. This is now in 2015. We look at a paper that they produced that was looking at biomechanical parameters that they were looking for to see those people who did respond to manipulation, how were they different to people who didn't respond? So in this study, they looked at a few physical parameters based on some previous evidence that these things are different in people who respond. So they looked at spinal stiffness, they looked at the multifidus thickness ratio, which gives an indication of contraction of those muscles, as well as something called the apparent diffusion coefficients of discs, which is supposed to be used as sort of a proxy for the nutrition that the disc is getting. It has to do with water content in the discs, and we see a difference in those people who respond. So what they saw they had a group of low back pain patients or subjects who had manipulation, a group of low back pain subjects who didn't have manipulation, and then they had an asymptomatic group that they used as a control, and they looked at certain parameters. And what they did see was there are changes in multifidus thickness if you are a responder. You'll see changes in the apparent diffusion coefficients of the discs and a change in stiffness. Now, these are biomechanical changes that we see in those who respond. But if we take a step back and look at this, this is a common problem, I think. I feel it's a problem that we see in the research, is that we look at people who have pain versus people who don't. And there's a bit of a chicken and egg that goes on here, because if you have pain, you are going to be different biomechanically. You're going to be holding your body differently. You're going to be moving differently. The way muscles engage is likely to be different because you're in pain rather than a cause of your pain. And if we look at this study, we see changes. So those people who did feel better, they had a reduction in stiffness, which could be a result of feeling better. They had a change in the muscular activation, which could be because you feel better, you're bracing less. And that increased engagement of the multifidus muscle is going to create a different compressive force on the disc, which then could change those coefficients. So it seems to me that this could be chicken or egg. We could be seeing the effects of having less pain rather than something that would be predictive or causative for why you had pain. So that can be an issue that we'll talk about in a little bit in many papers. Next, we're looking at subgrouping. Now, Peter O'Sullivan has done some amazing work in this, the search for a way to appropriately subgroup patients and finding subgrouping categories. And he's examined it, and he had some great frameworks that he initially started with and studied. And being a good scientist, his hypothesis didn't hold up to scrutiny. And so from what I understand, he has gone away from the idea that we can subgroup. And I feel confident that you could say his current assertion is that individualized patient-centered approach is needed to identify the specific factors that are impacting that patient's experience. In other words, the psychological subgrouping is another mythical creature that we should be cautious about chasing. It's very individual. What happens with that patient is unique, and understanding what's going on with that individual patient is likely a better place to spend our time and energy rather than trying to figure out a way to subgroup them, especially into a mechanical subgroup. Next up is we're going back to Greg Kotchuk, working with a different lead author this time, but Julie Fritz is also in on this paper. The lead author, I hope I can get it. I feel like I'm going to butcher their name. It's Hadezada. I apologize for mispronouncing that. I feel like I probably am. But what this group looked at was a group of patients, and they looked at many different factors to see if they could identify. It was an existing group of patients that had been treated. I believe it was the previous Kotchuk group that they were looking at. And they looked at many parameters, and they ended up with an 8 factor algorithm that would predict who's going to respond to manipulation. And these factors, most of them are not clinically evaluated factors. They include height, gender, whether you've had neck or upper back pain, your pain frequency in the last 6 months, the expectations, the patient or subject's expectations on medications and strengthening exercises, their score on a start back tool, and then the final thing that is a clinical evaluation is their extension status. So how I think symptomology in extension, whether it peripheralizes or not. So this raft of parameters that increase your confidence that they will respond to manipulation. And it's relatively sensitive, around 70-something%, and relatively specific. So this is an interesting, quite extensive group of parameters that need to be examined. But it is giving us some input. It might be a little complicated, and perhaps going back to what I talked about with what I believe Peter O'Sullivan's approach is that individualized care. So that might be the better approach. And when you look at this, this is people's response to care. So a trial of manipulation, if we just do a couple of treatments using a specific intervention, well, we usually get to understand whether or not the patient's going to respond, because we should know relatively quickly whether they're going to respond. So that might be a better pragmatic approach than trying to look at these formulas with this clinical prediction rule. That seems to be an easier way to go. And if we look at how much money we're spending on doing these different studies, where I think the money could be better spent looking at ways we can educate the population to change the narrative on the pathologizing of low back pain. But that's a whole other talk, I believe. So we're now going to talk about a little bit why I believe the search exists for this biomechanical predictor. I think it starts with our education. When we look at people who are manual therapists, whether that be physiotherapists, chiropractors, massage therapists, osteopaths, anybody in the realm of manual therapy, we are taught through a strictly biomechanical lens. It's still very prevalent in our education, in our continuing education courses, in the narratives that we see throughout media. It's prevalent throughout society that biomechanics are important. Even you talk to patients are constantly searching for the thing that they did, the biomechanical thing that they did that caused their flare-up of their back pain. And it's an interesting exercise to discuss with patients other factors that could play a role other than a biomechanical thing. And oftentimes that discussion will lead to a very fruitful aha moment for the patient to realize that perhaps it was stress or another factor that caused their flare-up that has no biomechanical explanation. So there's many factors that have to do with our education and our ongoing narratives in society that drive this. But additionally, I feel that our search for this exists because we love to see patterns as humans. Patterns are how our brain works. We see things when they're not actually there. They just resemble something that we've seen in the past. And so this is our obvious expression of that pattern-seeking behavior. And being empathetic, caring humans, and believing that if we can find a pattern, we can treat people more effectively, more cost effectively, not wasting time and money on those people who won't respond. We desperately want to find that pattern. So I think it emerges from a place of empathy and wanting to do the best we can and help the system work as best it can and reduce suffering. But the fact that we are such strong pattern seekers, I believe, plays a role in our continued desire to find something that expresses as a pattern. As we can see in these images, we search for patterns, right? We always see all of these faces and where there are none, where it's just the spatial orientation of those things is consistent with what we see as a face. So I found this pretty fascinating video. Another factor which I think plays a role in why the search persists is linked to what I was talking about with the first Kawchuk paper that I discussed with Kawchuk and Wong, where we falsely attribute an effect to actually being the cause, because we tend to look at people with pain in juxtaposition to those without pain. And we can find lots of research where we have comparators between a group with low back pain and a group that doesn't have low back pain, and we find differences. If we look here, there's 13 different papers from the last 5 years that compare low back pain versus healthy controls. So having a different view on this, I think, is critical, because think about the dollars spent on that research that probably could have been better spent if we understood the condition better, if we didn't try to push people into biomechanical subgroups and look for a mechanical cause and effect, which is a whole other can of worms when we think about cause and effect. Are we falsely attributing a complex series of interactions to a simplistic cause and effect narrative? That's an interesting discussion to be had, that is being had with podcasts such as Oliver Thompson and his series that is Cause Health. I would highly recommend that for everybody to listen to. It's a fascinating exploration of this cause and effect narrative that we do research based on, that we create policy based on, and how we treat patients based on these assumptions that are made. The final piece of why I think the search persists has to do with how we view the world of research and the biases that we have. I believe that multiple factors come into play that cause us to be biased towards quantitative research. And therefore, we hold on to quantitative research, so we look for biomechanical things that we can measure. What are the things that we can measure with certainty, with exactness, these biomechanical things, as opposed to where I think we would have more fruitful results is using qualitative research, which traditionally has been less valued than quantitative research. Although I feel that the tide is turning on that. I feel that turning tide is partially due to our better understanding of the complexity of humans and complexity of the pain experience that is allowing or that is funding and validating qualitative and mixed method study designs. And I think that's where we're going to likely have better results in looking for why our treatments have effect. We have to figure out what's going on with the human in front of us and understand with more complexity. And that complexity, I believe, can be explored better through qualitative research rather than quantitative. So this view of quantitative being more valid and qualitative being sort of woo-woo, and our hard push against being seen as flaky or more in the woo realm of things, I think has inadvertently caused us to push against research that would be better for our goals. I'm very optimistic about where the research is headed. Since that conversation that Corey and I had back in 2019, there's an expanded understanding that the parameters that will give us the best chance to identify people who will respond well to care, we're leaning towards an understanding of what they're thinking and feeling. It's more of that whole person approach. And if we look at published studies as well as the emergence of papers expanding on the biopsychosocial model, such as Peter Stilwell's paper on the inactive approach, looking at that more comprehensive understanding of what the pain experience is and what are the things we can look at to help predict. If we look at De Silva's paper, this is looking at the predictors for recovery, not specifically to a certain treatment intervention, but overall looking at what are the predictors of someone recovering from a low back pain episode. There are 5 predictors. The duration of the current episode, the number of previous episodes, pain intensity at onset, and pain intensity change in the first week, as well as depression score. So these parameters help on a grid to help you determine whether or not someone is going to recover at 1 week, 1 month, or 3 months. It's just a different take on looking at recovery rather than looking at what is the prediction of your poor outcome. So coming to the end of this presentation, one of the things that I think we should be cautious about, one of the things that we should gild ourselves against, is the potential for switching from the Sasquatch to the unicorn, going from a biomechanical explanation or searching for that biomechanical explanation or predictor, moving to a psychological predictor or another univariate type of explanation to predict who will respond to care. And since we're pattern seekers and we've been trained in the biomechanical realm and our process that leads to cause and effect, all of these factors on how we're built can have us slip there fairly easily. So I really caution against switching to a unicorn rather than a Sasquatch. I feel like perhaps the route that De Silva has gone in not looking at a specific intervention, but looking generally, is someone likely to recover, will be helpful. Secondarily, we do see several papers that indicate that one of the best predictors for a patient's recovery is their expectation on whether they're going to recover. So if we spent a little bit more time and energy on exploring that aspect, perhaps studies on when patients' expectations are poor, can we change their expectations, and how do we best change their expectations, may lead to better recovery. These are some of the ideas that I have as I think through where we could go with research. As I was preparing for this presentation, I was going through some pictures that I had from a trip that my sons and I took to a place called Harrison Hot Springs. And it's the land of the Sasquatch. And I thought this was a good example of how we are pattern seekers. The boys found this rock formation in Othello Canyon, and it reminded them, as you can see, of Donkey Kong. So I thought that was amusing and could end our time together here with a bit of joy and humor. And I want to say thank you. This is at Harrison Hot Springs, a couple of pictures from there. So I thought it would be a joyful way to end the presentation. If you want to look for more information, I can be found at drrichardmcilmoyle.com, as well as on Instagram at McIlmoyleRichard. So thank you very much and for taking the time, and I look forward to some fruitful conversations on the weekend of the summit. I also look forward to hearing all of the other presenters. Thank you.